a relative short period of time, probably within 1 to 2 years, we'll have anti-PD-1 antibodies on the market based on the data that's out there. I don't know anything, I don't have an insider's view, but from just knowing the data and knowing that the phase 3 trials are being accrued, I think those drugs will be available. And they seem to be a little bit easier to give than, say, ipilimumab or high-dose IL-2, and they're clearly more effective than those drugs, at least when you look at similar types of studies. They're now being compared head-to-head. So I think that those drugs, without question, are emerging and are here. In terms of other therapies that are emerging, if we begin to think about therapies that we're going to be either combining with BRAF inhibitors or combining with MEK inhibitors for non-BRAF mutant melanoma, I think we'll begin to see the CDK4/6 inhibitors emerge. I think we'll begin to see therapies that target apoptosis emerge. I think we'll begin to see therapies that target the way that certain melanoma cells get around the blockade of these things, the so-called HSP90 inhibitors, which do a really nice job of inhibiting the proteins that are able to thrive in the setting of targeted therapy. I think these are some of the agents that are emerging that aren't the PD-1 antibodies or the PD-L1 antibodies or BRAF inhibitors or MEK inhibitors. They're there, and then I think there are targeted therapies for ocular melanoma that have promise, and MEK inhibitors clearly have promise because there's been a randomized phase 2 study that says this is something that may be a really good way of treating that disease. And there are now protein kinase C inhibitors, and we're looking at immunotherapy in that disease. So I think pretty much all the subgroups of melanoma there are targeted therapies for, and as we learn more about the biology, we'll continue to develop more and more therapies, and most importantly, combinations of therapies.